This year in Lugano at the plenary session, we've seen presentation of two studies combining lenalidomide with R-CHOP, and those two studies were highly awaited for quite a long time. So this was a very exciting session in this regard. The first study was called Robust study, and this study was a large randomized phase 3 study, which included patients with ABC subtype of diffuse large B-cell lymphoma. Now, ABC subtype of diffuse large B-cell lymphoma is typically associated with poor prognosis, and previously done studies at Mayo Clinic and by our Italian colleagues show that addition of lenalidomide to R-CHOP could improve outcome of patients with ABC diffuse large B-cell lymphoma. Those single-arm phase 2 studies led to design of the presented phase 3 study. In this design, eligible patients were only patients with ABC subtype of diffuse large B-cell lymphoma as defined by gene expression profiling done centrally on a platform called NanoStrings. So it was very innovative in terms of biomarkers, using state-of-the-art biomarker to identify patients with ABC subtype which could truly benefit from addition of lenalidomide. Those patients were randomized 1-to-1 after stratification for IPI and age to lenalidomide plus R-CHOP versus R-CHOP plus placebo, and then followed for the outcome. Unfortunately, the primary endpoint of the study, progression-free survival, showed no difference between experimental arm and the control arm. So this was somewhat disappointing to all of us which participated in this study, because we felt the study was well designed and targeting the population in need. Looking at the data from the study, there was no new safety signals, and the exposure to lenalidomide was appropriate. So we looked for potential reasons for this study being negative, and one of the factors which could change the result of the study was that the patient did require to have this ABC subtype being done prior to accrual to the trial. And we now know that time from diagnosis to treatment is extremely important and prognostic. So if you wait for too long, if you have patients who are progressing slowly rather than quickly, and then you enroll those slowly progressing patients in the clinical trial, your control arm, the arm of standard therapy, is going to overperform. And as such, it is very difficult to show the difference. What was encouraging that in Robust trial, if you look at the high-risk patients with IPI 3 and above, there was a trend towards benefit for addition of lenalidomide to R-CHOP. So although primary endpoint was disappointing, I think we've learned a lot, and we did see some trend in high-risk patients. Now, the other study which was presented was ECOG 1412. And this is the study which was a randomized phase 2, so smaller randomized phase 2, but it included patients with all subtypes of diffuse large B-cell lymphoma, regardless of the cell of origin. And this was run in US only, was a multi-institutional intergroup study in which 3 groups, ECOG, SWOG, and Alliance, contributed to patient enrollment. In this study, we focused on accruing patients very rapidly on the study. I wanted to make it very accrual friendly. And what has happened, we did not require any central pathology verification prior to accrual, and there was no biomarker. So the time from diagnosis to treatment was relatively shorter in this study than in Robust. Similarly to Robust, patients were randomized to lenalidomide plus R-CHOP versus R-CHOP alone. And the dose of lenalidomide was actually higher, was given at 25 milligrams daily, but for a shorter time, for 10 days. And this was intentional because we wanted to maximize the synergy between R-CHOP and lenalidomide early in the cycle, and yet allow enough time for hematological recovery so the R-CHOP intensity can stay stable. So this study actually showed improvement in progression-free survival in patients treated with R-CHOP and lenalidomide. Patients treated in experimental arm with R-squared-CHOP, lenalidomide R-CHOP, had 34% reduction in risk of death or progression, which was statistically significant. Looking at the secondary endpoints in this study, like overall survival and response rate, there was also a trend towards improved outcomes. We also look at the cell of origin in this study, and we did not have it for all 280 patients, but we had it for 234 patients. About 40% of the patients are ABC subtype, And in this ABC subtype, again, we've seen the trend towards improved progression-free survival and overall survival for patients receiving both lenalidomide and R-CHOP as opposed to R-CHOP alone. So this result was very exciting and interesting, but it's still a phase 2 study in contrast to much larger phase 3 study, Robust, which was presented, which are already outlined here. And I think we'll have to spend more time comparing results of the study and better understand the differences to see how we can move forward. I actually see moving forward as potentially adding additional agents to R-squared CHOP backbone. I think in the recent years, we had a number of studies where single agent was added to R-CHOP in hope to improve the outcome over R-CHOP alone. And unfortunately, all those studies, randomized studies, were negative. We did not make progress now for 15 years or more. So I think it's time to start thinking about doing doublets or even triplets, so adding multiple agents to R-CHOP up front to improve outcomes of patients with diffuse large B-cell lymphoma.